Waiting for it to connect. Great, so we're recording. So good morning, everyone. I'm Nicola Oakenfull. I'm a trustee of Myeloma New Zealand. We're really excited that you and Dr. Urvi Shah from Memorial Sloan Kettering Cancer Centre in the United States are here for this webinar this morning. But just to explain a little bit about Myeloma New Zealand to start off with. Dr. Ken Romerall is a haematologist who set up Myeloma New Zealand in 2016 because he was frustrated at the lack of focus on myeloma and its treatment, particularly in that PharmAC funding process. And he's been a fierce myeloma warrior and advocate over the years. We're very grateful for the work that he did and the passion that he brought to the table until he stepped back from Myeloma New Zealand in August last year. Myeloma New Zealand has an overarching purpose of making myeloma manageable, and that's manageable for patients and families and carers. And to add another M word, we also want to make this disease matter to people and organisations that can change the outcome for patients, which includes PharmAC and its processes. So under that banner of making myeloma manageable, we have 3 areas of focus: advocating for new and improved treatments, or even just modern medicines, campaigning for equitable access to world-class patient care, and empowering patients through knowledge, such as this webinar. If you aren't signed up to our emails, then you can do that on the contact page on our website. We also have a Facebook group for patients, which is just called Myeloma New Zealand. So that's for patients and carers. And we have a separate one as well, just for carers. And when I say carers, I'm not meaning in the sense, like I would describe my husband as my carer. I work full time, you know, I'm in my early 40s, I'm pretty fit and active, but it doesn't mean that you're, you know, getting caring from them, but they're just your loved ones. And that page, if you can't find it, I think it's Myeloma New Zealand Carers and Loved Ones, it might be called, but let me know if you can't find it. The other thing as well is if you're not signed up with Leukemia and Blood Cancer New Zealand, we would absolutely encourage you to do that. We try not to double up too much in the services that we offer. And the other thing too is your local cancer society. Definitely sign up with them too. They have lots of things they can offer. For example, Wellington, they have free parking when you're at the hospital for your day ward treatments. As I said at the beginning, if you missed it, this session is going to be recorded. It will record whoever is the person that's talking. So when we get to the questions, if you want to ask a question but don't want to be on camera, you're welcome to put it in the chat and I can read it out for Dr. Shah. Or if you want to have your camera off, you're welcome to have your cameras on during the session as well. So I think that's pretty much it. I'll hand over to Dr. Shah. I think I'll get you to introduce yourself. So Dr. Urvi Shah is an oncologist hematologist at Memorial Sloan Kettering Cancer Centre in the United States. I'm so excited and just really grateful to have you here today. So, and just for everyone else, if you can please make sure that you've got your mute on. So if you're on the computer, it's down the bottom left. It should be the most left button. And if you're on your phone, you might need to tap the screen. It should probably be along the bottom somewhere, but if you can just make sure that you do that, please. And I'll just check that everyone, before I pass over to Dr. Shah, just check that everyone has got that. Otherwise, I'm just going to mute you, sorry, Steve. Otherwise, you'll end up being on the screen. And I think that should be everyone else. Great, Dr. Shah, over to you.
Hi everyone. Nicola, I think I can't share my screen yet. So if you could just enable screen sharing.
What? Oh, you can't screen share. Ah, okay, hold on. Let's see. What about now? Are you able to now?
Yeah, perfect.
Perfect.
Do you all see my screen?
Yes, we can. Yeah.
Awesome. So thank you so much for this invitation, and it's a pleasure to speak to you all. Feel free to put in questions in the chat and hopefully we can get to them at the end. I'll try to first just go over the evidence we have so far and then see if you have questions after. So these are my disclosures. So what food or supplements can I take? I think this is something that most patients, when they get diagnosed with cancer, have. It's the most likely question to be asked, but it's also the least likely to be answered question because there is evidence, but it's not, a lot of it is often not mainstream, or there haven't been enough trials done in heme malignancies specifically. So how do we adapt or say, is this specific for myeloma? We don't have all that information always, and so it is an unmet need, more research in this area. And with that goal, my focus has been as a researcher and physician to focus on nutrition and try to bring more evidence to it. So this is an example or a case of a patient that I saw in clinic, where this patient had multiple myeloma. The typical age of most patients is the average age, but the patient had lots of medical issues and also surgical issues. And so you can see, when a patient has so many other medical problems, it becomes hard for us to give them all the therapies that are available. So this patient was not a candidate for stem cell transplantation, CAR T cells, many clinical trials, and even intensive chemotherapy. And when a patient's not able to get some therapies, that automatically means that we're going to be able to offer them less when they need it. And that leads to a reduction in overall survival. So if you are skeptical of whether nutrition or overall being healthy affects outcomes for cancer directly, indirectly through being healthy to get the treatments, we can all agree that it definitely affects it. And what you can see here in green that I have marked are medical conditions which I think could have been prevented or avoided with a healthy lifestyle over their lifetime. So we surveyed over 400 patients a few years back, and we asked them questions about nutrition. And as you can see, and most of you may have experienced this, is that most patients have questions around nutrition. Most oncologists do not address it. And if the oncologist does address it, the patient often will attempt to make those changes or follow it. And what was most interesting to me was that when we asked patients before their plasma cell disorder diagnosis and after, was there any change in their food consumption of different food groups? And what we saw is that patients increased their consumptions of fruit, vegetables, whole grains, plant protein, and seafood, and reduced consumption of red meat and junk food. So patients are doing this on their own, whether we tell them or not. So it would be good if we can share evidence-based information for patients. So the American Institute of Cancer Research, if you're not familiar with it, here's the website. But this institute,
I can't get into this thing.
Are you okay there, Teresa?
It'll be over by the time I get it.
Are you not able to see Teresa? We can see you. Teresa, can you hear me? It's Nicola here. Are you able to see the screen? If you keep going, Dr. Sharon, I'll mute her.
okay.
I've just muted her.
These are the American Institute of Cancer Research guidelines, and you can see that what they do is they review hundreds and thousands of papers on nutrition and then come up with what's the summary of the evidence that's available for overall cancer prevention. And amongst the 10 guidelines of things people can do for a healthy lifestyle, 6 out of the 10 are for nutrition and healthy habits: eating more plant foods, reducing red and processed meat, sugary foods, fast food, and then alcohol and supplements are not necessary. They also have information on different foods. So if you click on each of these icons, they will give you the studies that are available, what are the active ingredients in the food, what it's known to, like what are the properties it has. And as you can see, all the anti-cancer foods or foods that fight cancer are plant-rich foods, and the foods to limit are red meat, sugary foods, and processed meats and alcohol. The next thing I wanted to talk about was with myeloma, and we have lifestyle risk factors such as an elevated BMI and diabetes, and this has been shown in multiple studies. Having an elevated BMI increases the risk of developing myeloma, but it also increases the risk of progression from the precursor states to developing myeloma. And these adipocytes or fat cells in the bone marrow and other places may be affecting myeloma cell growth through these different mechanisms. So there's lots more research going into this space, but when we published this review article a couple years ago, there was already so much evidence that we couldn't even fit it into the paper given the restrictions of the limit on the citations we could include. But however, unintentionally losing weight is also not a good thing. So when we're talking about this, it's like doing it in a healthy manner and sustained, and where you're not, where somebody's not like losing weight, gaining weight, or cycling of weight, or unintentionally like not eating and that's why losing weight. So thinking about it more in a healthy way, eating well, but eating the right foods instead of not eating. Another metabolic disorder, diabetes, we don't often think about this, but diabetes has also been linked to cancer risk. And about half of the population is pre-diabetic or diabetic in the US, and I'm sure it's maybe a little better in other countries, but not very different overall. And diet has been associated with cancer. Diabetes has been associated, and it's thought to be two ways. Like maybe you could say that the same genes, the same risk factors like age, bad diet.
Video.
It could be the same things as age, poor diet, or weight that leads to diabetes, but also leads to cancer. And or it could be that first these risk factors lead to diabetes, and the high insulin and high sugars lead to the increased risk of cancer. The risk is different for different cancers, but it is more in certain like solid tumors like pancreatic cancer. But with blood cancers also, there is a slight increased risk with diabetes. And we looked at it with myeloma, and it's not fully clear. In some studies, it seems like it may just be an association. But, I think, to me, I think like having diabetes also leads to worse outcomes once myeloma is diagnosed. So being able to keep diabetes under good control, or even reversing diabetes through eating healthier foods, is quite important to, again, improve survival. So this is a study in colorectal cancer, but I'd like to discuss it because, many times in myeloma, we talk about, okay, standard risk, high risk, we talk about genes, and we're focused on, okay, maybe I have high risk genes or I have standard risk genes, but we don't think about the genes are something that, okay, we've got with the myeloma, but there's not a lot we can do about it. But what we can do something about is the lifestyle, and risk of developing cancer can be modulated even if somebody has bad genes. So what you can see here is that they had 300,000 participants, and they followed them over time to see who developed colorectal cancer. They calculated a lifestyle score and a polygenic, meaning a genetic risk score. And then they looked at those who had the high genetic risk, the intermediate genetic risk, and low risk. They put them into 3 groups. And they also put them into 3 groups of healthy lifestyle and unhealthy and intermediate lifestyle. The unhealthy lifestyle had the highest risk of developing colorectal cancer when they had bad genes compared to the healthy lifestyle, right? You can see it's 5% compared to 9%. So it's like almost double. And also the healthy lifestyle with the high risk was similar almost to the intermediate risk group. So you can see that changing lifestyle can affect the risk of cancer development. And it's not only, okay, what the genes are. There's an interplay between genes and lifestyle. So another thing is what dietary patterns have been associated with cancer risk. And you could say who gets less cancer, or what leads to a reduced cancer risk. And a lot of nutrition studies are population studies, like, surveying patients before they get cancer. So surveying like thousands of patients. Each of these studies had 60,000 or 40,000 people. So it's huge studies. And then they all filled out a dietary survey. And then they were followed over time and then seen based on what diets, who got more cancer and who got less cancer. And they showed all these 3 studies, one from France, one from USA, and one from UK, all showed that about 15% or so, 15 to 20% less cancer in people who ate more plant-based foods. So eating more plant foods is associated with reduced risk of cancer. Once you have a cancer diagnosis, I think still reducing risk of secondary cancers, reducing risk of just overall survival and things like that are things to look at. So this is a study in myeloma specifically looking at diet, and they had over 400 myeloma diagnosis on this cohort. So it was a big study because myeloma is rare. You need to survey a lot of people before you see an outcome. And what you can see is those who ate healthier dietary patterns. So all of these dietary patterns that you see are plant-forward dietary patterns, meaning they're eating quite a bit of plant-based foods, Mediterranean, healthy eating index, DASH diet, prudent diet. And then these are the Western diet, inflammatory diets. And those who, before their myeloma diagnosis, and what they assume is what they ate before is what they're eating during, they had 15 to 24% lower likelihood of death from myeloma. And those who ate Western diets had a 16 to 24% higher likelihood of death from myeloma. So even if everything else is the same, like just how you eat can affect survival, by quite a bit, as you can see here. There was another study, the same Epic Oxford from the UK, where they had numbers of individual cancers as well. So they had evaluation of myeloma patients, and you can see there were only 65 myeloma cases. So it's a small study, but they showed that there was a 77% less likelihood of myeloma in the vegans or vegetarians compared to meat eaters. Now, you could say this is a small study, and I totally agree with you that there are only 65 myeloma cases here. This one had 423 myeloma cases, but myeloma is a rare diagnosis. So, we don't have too many studies, but we've done 2 studies, and I'll just show you that now. So with MGUS, and if some of you are not familiar with the term, MGUS is the precursor state or like before myeloma develops the abnormal protein in the blood. There aren't too many studies looking at MGUS and the risk of cancer, because it's usually a condition that's diagnosed through blood tests. We don't screen people regularly, but what you can see in this study that we've done, we are yet to publish it, but we presented it at ASCO, was that eating whole grains, so this is fruits, vegetables, was associated with a reduced risk of MGUS, whereas sugar sweetened beverage and increased risk of MGUS. And when you look at this, remember, these are carbohydrate rich foods, but these are complex carbohydrates. So we should not be fearing all carbs, but trying to avoid refined carbs, not complex carbohydrates like whole grains and fruits and vegetables. And then I showed you 2 studies, one with 65 myeloma cases, one with 400. And we've done an analysis with 1,300 myeloma cases in this different study. So this would be the largest one to date. And also we calculated, like, for patients, different dietary scores. So we looked at what is their diet pattern, and we use these different ways to measure dietary patterns. So a higher score means a healthy diet, a healthier diet based on that score. So one is like a Mediterranean diet, one is a healthy eating index, and a healthful plant-based diet index. And the one that ended up being significantly associated was that those who had the highest quartile, meaning the highest score, the 25% with the highest score, had a 15% lower risk of myeloma development, but we didn't see that with the other scores. So again, what you're seeing with all these studies is a very consistent theme. Just eating more plant foods overall is associated with better outcomes and less risk of cancer. And I bring this up because many people, when they have cancer, fear sugar and think that sugar feeds cancer, so they should avoid all grains and all sugar. While I agree with you, avoiding refined sugars like sugar, like desserts and cakes, is right, like even croissants or refined flour, you want to avoid all of that. But trying to incorporate whole grains into your diet, a few servings a day, is actually associated with reduced cancer risk. And you can see here, this is with colorectal cancer, but with also total cancer mortality, meaning death from total, like cancer-related deaths, and also cancer-specific deaths. And the recommended daily intake is about 3 servings of whole grains. And remember, whole grains are not just fiber. They have a lot of different things. They have vitamins, minerals, and antioxidants, and all of this, I think, combined is what leads to their anti-cancer properties. The next thing I wanted to talk to you about was red and processed meat, because this, I think, is the strongest evidence we have in nutrition and cancer, and not specifically for myeloma, but just overall cancer. So in 2015, the International Agency for Research on Cancer, so the IARC, met in, and 22 scientists reviewed over 800 studies. So a lot of review, like looking over studies, and then they looked at patterns and analyzed the data. And what they showed was the largest evidence is for colorectal cancer, pancreatic cancer, prostate cancer, stomach cancer. But with this evidence, they said data on the association of red meat and processed meat is quite clear. And after this, meat was considered processed meat is considered a group 1 carcinogen, meaning it definitely increases risk of cancer. And red meat is considered a probable carcinogen, meaning it most likely increases the risk of cancer. And processed meats include things like salami, bacon, sausages, hot dogs. So trying to avoid these foods, if you can, I think is important. If you do want to eat them or really like them, it should be something on a rare occasion, not a daily habit. And the same thing with, red meat and reducing consumption of that. So some of the mechanisms through which it is thought that red meat can increase risk of cancer is through these different gene signatures or different mechanisms that I've shown you here. Also, there's no fiber in animal-based foods or even red meat. And so some of this may be through the gut microbiome and through different compounds that are formed. There is a study, most of these studies in nutrition, because it's very hard to look at mechanisms when you have people like asking somebody to change their diet and stay on the different diet for decades, because sometimes nutrition changes take time to see effects. But this study I thought was very interesting, even though it's again colorectal cancer, but they were able to get genomic sequencing data. So they sequenced the genome, the tumor of these 900 colorectal cancer cases. And then they asked, they looked at the surveys of what food these 900 patients ate. And they showed that those that ate more red meat had more of this alkylating signature. So you can see this, the gray box means higher intake of red meat and the white box is lower intake. And you can see that the box is slightly increased for the overall unprocessed and processed red meat. And these numbers in red means they're significantly different between those who have high intake versus low intake for this signature. And so they said that they think that this signature, the alkylating signature in the tumor, is due to the red meat consumption. So this is one of the first time we're seeing like a mechanism of how diet's affecting the genes in the tumor. And then they also showed that those who had this mutational signature, the alkylating signature, and had the highest amount of it, so Q4 means they had the highest amount, actually had the shortest survival too. So they were able to show, that there is a genetic signature to what the person eats and it's affecting survival. So I think it's a very nice mechanistic study understanding how diet may affect cancer. Then I wanted to switch over a little bit and talk about gut microbiome and why it's important. So to remember, we are actually more microbiome genes and more microbiome cells than human cells or human genes. And while we see on the surface the human form, because the human cells are much larger and the microbiome cells are much smaller, we actually have microbes living inside of us, on us, and around us all the time. And so there is a symbiotic relationship or a relationship between the microbes and the human cells, and there's constant interaction between them. So we can no longer, ignore these microbiome, and we should be feeding the microbiome as well and thinking about how it plays a role in disease and health. And there's a lot of evidence now of how the microbiome may be affecting production of different, molecules that affect the immune system and affect different diseases such as inflammation, cancer, even cardiovascular disease, diabetes, all of them. But I think this is an area that we're just starting to see research in, but you're going to see a lot more of it to come. And so knowing that the microbiome can affect, cancer risk and also just overall other health conditions, I think a lot of it is through the immune system. The microbiome, it affects the immune system and other ways as well. So when we think about the immune system and, with COVID and other risks of infections, as well, not just like the immune system to fight the cancer, but the immune system to fight infections as well. How do we improve our immune system? There are a lot of things we can't do, we can't change, like, non-modifiable factors. But then we have things like modifiable factors as well, like nutrition, diet, obesity, diabetes, the microbiome, physical activity, sleep, stress. So the ones that I'm focusing on in my research are these 4, and we'll talk a little bit about that later. Other things is that this is a study in healthy individuals, and I want to show you how the microbiome can change quickly, but also the immune system can change quickly, and the cells growth can change quickly in a short time. So this was healthy Americans. So they took 20 African Americans and 20 rural Africans. So Africans from Africa and Africans from America. And they asked them to have 2 weeks of a diet and switch, two-week diet switch. So the African Americans ate the rural African diet and the rural Africans ate the African American diet. And so you can imagine the African Americans generally eat a Western diet, and rural Africans are eating a very high fiber diet with a lot of beans and plant-based foods. And what they showed here is that, so Ki67, you probably are not familiar with it, but it is a marker of cell proliferation. So if there's more Ki67, meaning more brown that you see here, it means that the cells are dividing faster or there is more of it available. They did colonoscopies before and after the diet switch. So they did biopsies of the normal mucosa of the lining of our gut before and after. And in just 2 weeks of this diet, they showed that this, you can see the brown here is much less. So when the African Americans went to the rural African diet, they had a reduction in this tumor proliferation index, and vice versa. You see the opposite in the rural Africans eating the African American diet. They also showed changes in the immune cells that are going into the mucosa, and they showed changes in the microbiome where there are more of these butyrate producing bacteria as well in the African Americans who eat the rural African diet. The microbiome improves as well. So small, quick changes can already, like in a few weeks, you can already start seeing changes. This was a study of stool samples taken from over 10,000 individuals, and then they looked to see what is associated with diversity of the microbiome. Diversity, think about it like a rainforest or something where there are many different species of animals, plants. So there's a good diversity, right? And that's needed for the habitat to balance itself out. The same way in the microbiome, we want good diversity, meaning we don't want all one kind of bug, but we want many different bacteria to be flourishing, because that leads to a much healthier microbiome. And so more diversity is a good thing. And they showed that if a person ate more than 30 plants a week, they had higher diversity than somebody who ate less than 10 plants a week. And what they mean by 30 plants is not eating broccoli 30 times in the week, because that would be the same plant, but eating 30 different kinds of plants. So trying to, go out of your comfort zone and pick fruits and vegetables and even beans, seeds, herbs, all of those things count. But if you eat, 5 different beans together and it's a mixed thing, then you would count that as 5 instead of 1, because you had 5 different kinds of beans in it. And so I think trying to get diversity of plant foods leads to less antibiotic resistance. So when infections do develop, also that's a reduced risk of that as well. Diet can also affect the immune system. And so this study with just 18 participants, they asked them to eat more dietary fiber. So this is not fiber supplements, but eating foods with fiber. And only plant foods have fiber. You don't get fiber from animal-based foods. So they made them add 20 grams of fiber to their diet for 4 weeks and showed that the microbiome function improved. And they also tried, another group of participants were asked to eat fermented foods, about 6 servings a day for 4 weeks. And they showed that the diversity improved and inflammation reduced. So again, similar theme of like eating a variety of foods, but also eating fermented foods, high fiber rich foods. So far we've just talked about different food components and how it affects the microbiome as well. But I wanted to move over to thinking about like how we study this in cancer and how do we show that it's affecting outcomes for patients, and what we have done so far in research and what's been done in other cancers as well, and how we can move this field forward. So I think dietary interventions in cancer are through the prevention, can be thought about as prevention. So you want to prevent development of cancer in the first place, but if cancer does develop, we want to prevent secondary cancers, prevent other medical problems, all of that. And the American Institute of Cancer Research does say about 1/3 of the most common cancers could be prevented through just diet, weight, and physical activity. The next thing we'll talk about is treatment, and how can dietary interventions be done simultaneously with treatment to actually reduce comorbidities, allow better treatment, but maybe also improve response rates through treatment. And then the last thing is post the treatment's over, when patients are in the survivorship mode or like just following the cancer on maintenance therapy, how do we reduce risk of cancer and delay cancer from coming back? So we'll start with a prevention example first. And we do know that, I remember I told you that if you have a precursor disorder and an elevated BMI, those patients are twice as likely to progress to myeloma. And so we decided to study this, and there's a lot of information. I've already showed you a lot of this evidence of how metabolic factors, diet, the microbiome can affect risk of cancer development. And then I'm sure, so what we're trying to, what we wanted to do with this study was, can we help patients improve their diet and change these lifestyle factors? And can we see if this delays progression to myeloma for some patients at least? So this was the Nutrivention trial that we did. And in this study, we only had 20 participants because it was our first pilot study. But these are patients with precancerous states, MGUS and smoldering myeloma. Before they developed myeloma, they had an elevated BMI over 25. And we gave them 3 months of unprocessed plant-based meals. We would ship them lunch and dinner, but give them recipes for breakfast, snacks, and allow them to eat as much as they wanted, but just make sure that they're eating mainly plant-based foods, and also nutrition coaching for 6 months, and then we followed them for a year. The study has finished enrollment, and the study, we're at the process of wrapping up the study now. So some of the data I can show you is that we enrolled a nice balance of patients. Some were MGUS, some were smoldering. They were all between different BMI categories. We also had 1/3 of patients who were pre-diabetic. And we had very few patients that dropped out of the study. We had 3 patients drop out in the first 12 weeks of the intervention, 2 of them for medical reasons, others separate from the study, and 1 just didn't feel like they could do it or wanted to do it anymore. And then we had 2 patients who were lost to follow-up after 12 weeks. So they finished the intervention, but they moved and were not interested in following up on the study anymore. But we had 18 patients who actually went from the start of the study to finish the study 1 year later. And while the study, we still have a few visits pending for patients. Most of them are on track to complete it. And what we can show you is that at baseline, before they went on the study, most patients' diet was about 20% unprocessed plant foods. So amongst all the calories they ate, on average, they were only eating 20% of unprocessed plant foods. On the intervention, it increased to 92%. And post the intervention, it stayed at 73%, so pretty good compared to where they started. And even their fiber intake increased from 18 grams per day to 30 grams, and then went down maybe a little bit to 24 grams, but still much better. It's important to note that 30 grams of fiber is actually the recommended daily allowance for fiber. So most people are not meeting the fiber requirement, and then these patients on the intervention actually met the fiber requirement. What we did see is that patients, because these were elevated BMI patients did lose weight, about 7 to 8% of their body weight on average at 12 weeks, so in 3 months. They also improved their hemoglobin A1C, their cholesterol, insulin, improved microbiome as well, and reduction in inflammation for some of them who had elevated markers. You can see here that this is a marker of insulin resistance. So it actually improved, meaning it's better, that they had less insulin resistance in the study after. So these patients were eating more carbs than ever because it's a plant-based diet, but these were all complex carbs. So eating more carbs doesn't mean you're going to develop insulin resistance or more diabetes. You can see that their diabetes markers improved, insulin improved despite eating more carbs. But remember, they were eating complex carbs, not refined carbs. And I think that's very important to note. Also, you can see that there was an improvement in their microbiome. So I wanted to just show you an example of 2 cases on the study. So this was a patient who had 2 other cancers in 2010 and had surgery, then developed MGUS in 2016, and an M spike at that time was 0.24. This patient had diabetes for 30 years before they went on the study, and they were on insulin for 30 years, and also on these other medications for diabetes. Many other medical problems, as you can see here. In 2021, they started the study. Within a month of starting the study, they stopped insulin. They didn't need it anymore. It's been a year and a half since the study, and they've not needed to go back on insulin yet. So diabetes is reversible for majority of patients if we're eating the right way, and it's possible. What you can see here is this patient had been losing some weight before the study, but on the intervention, very significantly lost weight and went into a normal BMI. This is on the intervention. But you can also see here that they had improvement in their BMI, they had improvement in insulin levels. So that's a good sign, like their diabetes is improving. They also had insulin resistance also improved. And you might be asking, what about the myeloma markers? And we did see that before the intervention, it seemed like it was rising over the years. So from 2016 to 2021, you can see that it had a slow increase in this brown line. And then on the intervention, it seems to have stabilized for a year and a half. So these are numbers from a year and a half of the study. This patient had bad kidney disease as well due to the diabetes, but that also seems to have stabilized or delayed in terms of getting worse. And I'll show you that there is evidence around kidney disease and diet and nutrition too, and why it's important. And so with that pilot study, even though it's a small study in 20 patients, we're now doing a much larger study with 150 patients. And in this study, it's a very similar study, except that we also are looking at the effect of supplements like curcumin and omega-3 and its effects on progression to myeloma. So that study is currently enrolling, and hopefully in a few years, we'll be able to talk about the results. It's enrolling quickly. Now we talked about the prevention setting, and now I'll talk about the treatment setting. So can diet affect outcomes like, likelihood of complete remission, overall survival, progression-free survival, quality of life? So can it, be an additive or synergistic to standard of care options? We don't know in myeloma because it's not been studied yet. But we know from this leukemia, this trial was done with 40 patients, and they asked them to only for a month during the first cycle of chemo, they made them eat much healthier, but also made them eat little less calories. So there was a calorie deficit of 20%. And what you can see is that, again, this is the same adiponectin-leptin ratio I talked about. So insulin resistance improved. But they also compared to a population who was treated very similarly to the population on the study who got this intervention. And they showed that the patients who had MRD negativity or likelihood of complete remission were higher on the study than who didn't do this intervention. So what they're showing is that maybe dietary interventions improve the likelihood of complete remission. Again, we don't have data in myeloma. This is a small study. Still, there's lots to be learned in this area. But since these are low-risk interventions of just eating healthier, I wanted to show it to you so you can make decisions for yourself. Another study in melanoma, so this is skin cancer. What they did is patients on immune checkpoint blockers, so in immune therapy, they didn't give them any food or ask them to eat, but they just asked questions around how much fiber they ate in their diet. And those who ate the highest dietary fiber, so a sufficient amount, without probiotic use actually had the longest progression-free survival or longer survival than those who didn't get sufficient fiber. So showing that adequate fiber delayed progression of the cancer. And then in the survivorship setting, if we think about can diet and lifestyle prolong the time in remission and delay relapse, and maybe some patients keep them in remission forever. And so this is something we studied in myeloma patients on lenalidomide maintenance. We collected stool samples and dietary information. We asked patients to fill out a survey. And then we looked at, does diet affect the microbiome and does it affect outcomes? So we studied these three areas. And what we did see was that patients who had higher diversity, remember I told you diversity is a good thing because it's variety. So those who had higher diversity in their stool, meaning more different kinds of microbes or bacteria, actually were more likely to be in complete remission. Those who had higher butyrate producers, and again, butyrate producers are healthier bacteria, and we saw that increase in our pilot study with the nutrition and eating more plant-based foods, had higher butyrate producers had higher likelihood of complete remission, and the same thing with butyrate concentrations. We also looked at dietary indexes, and we saw that people who eat healthier protein, so this is mainly more like from the plant protein effect, but you can see that higher, healthier protein is associated with higher butyrate levels and higher likelihood of being in complete remission. And the same thing with dietary flavonoids or plant chemicals. So flavonoids only come from plant-based foods, or plant chemicals are associated with this butyrate concentration. So given that, like what we're showing you is that diet may affect the gut microbiome, may affect myeloma control, and we're doing a study to try to understand that currently a little better. So now I'll just switch to some practical tips on how we can do this for the next 5 minutes, and then we should be done for questions. So the fiber gap, I don't know if you've heard of this, but remember I told you the recommended daily intake is about 30 grams of fiber. If I ask most people and say, do you get enough fiber? Most will say yes, because 67% of consumers think they're getting enough fiber. But in reality, only 5% actually do. So most people think, oh, I'm getting enough fiber, but actually only 5% are getting enough fiber. So you want to be one of those 5% and not the 67% who think they're getting it. And fiber is important because, it protects the lining of the mucosa of the gut. And when it protects that, it prevents infections, inflammation, all of these things from happening. So you want to be thinking about it. And when you think about fiber, so I just, this is a very arbitrary like food, just to give you an understanding of where fiber comes from, but also how do you meet 30 grams a day. So these are the requirements. Females 25 grams and males 38 grams is the ideal fiber intake requirement. So if somebody eating mainly animal-based foods, what you can see is that no animal-based food has fiber. It's all 0 grams everywhere you see. This person, the only fiber they're getting from is eating a bag of broccoli, the slice of bread, the potato, and the white rice. But if they're on a plant-based diet, everything they eat has fiber. And so this person is meeting and exceeding the fiber requirements, whereas this person is not meeting their fiber requirements. Now you'll say, what about protein? And I wanted to show you, so this is exactly the same diet, but if we were thinking about protein, and remember that the recommended daily intake of protein is 0.8 to 1.2 grams per kilo. If a person is 60 kilos, that's 48 to 72 grams. But remember, this is for the majority to meet their requirements. So there are some people who will need less protein, but this is when a recommended daily intake is so that 90% of the population meet their requirements, but there are going to be people on the other end who don't need as much. So I think when somebody meets 0.8 or 1.2 grams, they're getting more than enough protein. If we say somebody's older, somebody has cancer, maybe they need a little more. So it could be 1 gram or 1.2 grams instead of 0.8 grams, but still it's within that range. So at the higher end for a 60 kilo person, it would be 72 grams. And you can see that this plant-based diet is also meeting the protein requirements, but that's because they're also eating things like beans, nuts, seeds, oatmeal, whole grains, all of that, and not just salads or fruits and vegetables. And I think sometimes when people think of a plant-based diet, they think, oh, I have to only eat salads. No, you can eat cooked foods, you can eat lentils, you can eat beans. So whatever you make, generally, you just switch it out. So if you were putting chicken and something, you put tofu instead, and you've just made a plant-based meal and you've not changed too much else in the recipe. So things like that. And you can see here that this is way exceeding the protein requirements. And very high protein diets are associated with increased mortality, but also increased kidney disease risk. So this study looked at animal and plant protein and said, what's better in terms of just risk of death overall? And this was published in a very high impact or a big journal in 2016. And when you see these lines or these black boxes to the side which favors plant protein, that means that the evidence is showing that for each of these food groups, eating plant protein is associated with a reduced risk of death. But if this box was on the right side, like favors alternate source, that means it would say that eating animal protein was better. And you can see here that for higher intake of animal protein is positively associated with mortality. And the inverse is true for high intake of plant protein, especially amongst individuals with at least one lifestyle risk factor. And in this day and age, most people have one lifestyle risk factor, either high cholesterol or diabetes or obesity or cancer or things like that. So again, prioritizing plant over animal protein is, I think, very important. When we're individualizing nutrition changes, remember, I'm not doing this to overwhelm you or stress you out or feel like you need to change everything in your pantry, but think about it as evidence or information you can use when you are at the right stage or feel receptive to hear about it and you're not overwhelmed. I also think, it's important if somebody's on treatment, they have to take into consideration the side effects from treatment, how they're tolerating. Because if they try to just switch and they're not eating at all, then that's not going to be helpful. And it's important to make the changes gradual so that they're sustainable. Often people will hear things like this and they'll be like, okay, from tomorrow I'm going to completely do this, but then they haven't really thought about how they're going to do it. And then they're more hungry than, really able to do it. And then after a week, they're like, this is not sustainable. I can't do this. It's not for me. But if you try to make switches one step at a time, like you say, okay, today I'm going to switch out the meat for the beans and then do only one meal a day like that or something, then you're making your body adjust to it, but you're also able to do it sustainably. For some people, doing it cold turkey works though, where they just completely stop, same as like, when somebody has an addiction to something and they decide like, okay, I'm just going to give it up completely. So you have to decide the kind of person you are and how you want to do it. In terms of some practical tips to consider, we've talked about all of these things through the talk, and I'll talk a little bit about vitamin D as well. Remember, calorie counting and calorie restriction are difficult to sustain long term. Meal planning and preparation in advance goes a long way. If you are super hungry and you have to decide what to eat, you're really going to pick the fast food because that's what's easy to get and you have it at home. But if you thought about like once a week, maybe preparing meals, freezing them so you can just heat up the box when it's ready, when you're hungry, you already have a good choice available to you. So making switches that are more sustainable and possible. Another thing that we didn't talk about, but vitamin D is, I would say that we don't have a study in myeloma where we've given patients with myeloma vitamin D and seen if it affects survival or it changes things. And those studies are extremely big and expensive to run and take years. What we do have is that patients who have lower levels, what happens and what is the risk. So we know that patients with lower vitamin D levels have reduced overall survival, have more likely to have more inflammation, more likely to have decreased bone density, more low calcium when they get the bone strengtheners, reduction in survival and things like that. So I think if you can get your vitamin D levels checked and try to keep the levels over 30 is a good thing, but you don't want them to go very high because too high is also toxic. So you want them to stay somewhere between 30 to 50. Another common question we get is organic foods and cancer risk. And so I wanted to show you this French study that said that those who ate more organic foods might have had less risk of cancer, but it was not significant for any of the other like cancers overall, but it was mainly, just for overall cancer risk and maybe for some of these like lymphoma it was. But remember that when we talk about organic food and cancer risk in these association studies, it is all self-reported what a patient says they're eating, but it is also like people who eat organic food are more likely to exercise, are more likely to live a healthier lifestyle. So is it really the healthy lifestyle or is it the organic food reducing the cancer risk? So should you only eat organic foods? And I think that this, website basically does a nice job of explaining why you shouldn't worry so much about it, but just make sure you get enough fruits and vegetables in your diet. Is that you can put in or plug in different fruit foods, and then you can ask whether it's a female or a male and say like how many servings in one day should somebody eat without having any effect if they had the highest pesticide residue. So somebody could eat 450 plus servings of strawberries without having any side effects from pesticide residues, and which nobody would ever be doing. So, when we are eating small amounts, that effect is not a major issue. Another study had looked at this some time ago. If 1/2 of the US population were to increase fruit and vegetable consumption just by 1 serving a day, an estimated 20,000 cancer cases might be avoided each year. But in contrast, the pesticide residues on those fruits and vegetables that they start eating may lead to 10 extra cancer cases in the whole year. So they were 20,000 less cases and maybe 10 increased cases. So it's still on the net going to be less cancer risk. So what I'm trying to say to you is that if you feel like and you have the money or the time to find and look for organic, sure, you can do that. But if you don't, I think it's more important to eat your fruits and vegetables than to worry about organic, because even on organic foods, there might be some slight residue of pesticide. And when people worry about pesticides on plant foods and think that animal foods don't have them, that's also a myth, because the animals are eating these plant foods and then we eat the animals, so they get the pesticides and indirectly we get it through them. So it doesn't mean that just because you eat animal foods, you're avoiding this pesticide risk. This is a good website for diet and kidney disease. So if you have want to look for more information, and if you have kidney disease, I would refer you to this website. And then when we think about plant-based diets, they can be, what am I talking about? So a vegan diet is 0 animal products, but it doesn't have to be healthy, because it's often done because of the person feels very strongly about animal welfare, climate change. And I think those are very important issues. But when we're talking about health, a vegan diet can be, you can eat Oreos, you can eat French fries, and you can still be vegan. So veganism is not really a diet, but it is a lifestyle of no harm or trying to minimize harm to animals. When we talk about vegetarianism, also very similar, often driven by religious or ethical reasons, and people will not eat meat or fish, but eggs and dairy is allowed usually on this diet. But again, it doesn't have to be healthy, because you could again eat a lot of cheese, a lot of dairy, and then eat a lot of fried foods and things like that. And then a plant-based diet is what I'm really talking about here, is minimizing animal products. You can see this food plate from the Canadian food plate. A quarter of the plate is mostly plant proteins. There may be a little bit of meat here, but it's a really small amount. Half the plate is fruit and vegetable, and a quarter is carbohydrates. And so focusing on getting the majority of your calories from unprocessed plant foods, whether you want to be a whole food, plant-based, vegan, vegetarian, pescatarian, whatever suits you. But I think it's important to note that, some people are not able to differentiate that last 5-10%. So it can often be easier to do it as a vegan and just cut out all animal products, because then you're able to do it. But for some people, that's too much. And they're like, no, I'd rather do it like only 10%, 20%. So you have to decide how it works for you. But I think trying to get 80%, 90% of your calories from unprocessed plant foods is really the healthy way to go. This is a study we're going to be doing in the US that's opening soon. I'll skip it over in the interest of time. These were 2 surveys we are doing through the Health Tree Foundation. I'm not sure if you all have heard of the Health Tree Foundation, but if it's possible for you to sign up to, you don't even have to sign up, but you can just scan this QR code or click on this link, and then you can reach the surveys. But we are doing a survey to understand dietary patterns of myeloma patients. And this is the same survey that, all these studies I showed you that happen, like these are the kinds of surveys people fill out, and then we can see the effects. So if you have about 30 minutes to fill this out, it would be really helpful for us as we try to study and understand this for myeloma patients. We're also trying to understand what supplements patients use, and this is another survey we are doing, and both these are on their website if you have the time to fill it out. And then these are our trials. I don't think this is applicable for you all because it's in New Zealand, and the trials we are doing in the US, but just thinking about how diet can affect plasma cell disorder outcomes. And if you want to read a little bit more, these are 2 papers we published in the last few years on how diet affects cancer and how diet may affect myeloma as well, and outcomes. So a lot of the things I talked about, but in more detail. And then the last thing I wanted to say was that when you choose a healthy diet, yes, that's good for your own personal health, but you're also benefiting the planet, like climate change, very significantly. And just so you know, 1 serving of beef, for instance, or ruminant meat has a carbon dioxide equivalent, meaning the greenhouse gas or warming potential of 1200. Whereas 1 serving of bean has a warming potential of less than 1. So it's 1200 times more detrimental to the environment to eat 1 serving of beef compared to 1 serving of beans. Pork is about 200 times more. So just switching to eating more healthy foods is going to be beneficial for your children, your grandchildren, and the planet overall. So it's good in all ways for both yourself and in general. And then I just want to thank my collaborators, patients who've taken part in these studies, funding, and all of you for listening. If you want, more information to the papers we've written or research, and even some of the other talks I've given, you can go to this link and you'll find all of it there. And I do post sometimes on social media about all of this in case you wanted to, follow for updates. Thank you.
That's fantastic. Thank you so much. And that was one of the things I was going to say as well, is if you're on Twitter or Instagram, then I would definitely suggest following Dr. Shah. There's also some really good videos online, on YouTube as well, with Health Tree for Myeloma and some other organizations. And if you go to Dr. Shah's social media, she has that link, which has them. Just one thing which I put in the chat just to remind for the New Zealand patients. So the M spike is what we would call a paraprotein, and I don't know what to call it, the amount thing is different. So the 0.24, that's a 2.4 for us. And MRD negativity, I might get you to explain it, Dr. Shah, because you'll be better. But in New Zealand, I think Auckland is the only place that has the ability to test it for it. It's not something that we routinely test for in New Zealand, although it's something that we would hope that in the future it becomes more routine. And there are some patients, so say, for example, I know some high-risk patients have had it done before considering if they had a tandem. Do you want to just explain a little bit about what MRD negativity is?
Sure. So MRD negativity is the likelihood of having no evidence of myeloma. I mean, not likelihood, but MRD negativity means there's minimal residual disease. Negativity state means there's no evidence of myeloma cells in the bone marrow by the test that we are doing. And these tests go very deep into the bone marrow. So 1 in 1 million cells is as sensitive as they are. So if there was even 1 in 1 million cells, they can find it with these tests. What I think is it's okay if your doctor doesn't test for MRD negativity. I don't think that, as of yet, we know how to fully use it for clinical change, like meaning to change treatment. If somebody's MRD positive, should we escalate treatment? Or if they're MRD negative, should we de-escalate treatment? A lot of research is going into that just now, but there are no clear guidelines on it. What we do know is that if a patient achieves that MRD negative status, then there is a higher likelihood they'll stay in remission longer. So it's good for research to understand, like, how do we get the disease into better control? And just it's only worth testing for MRD negativity if you can't find disease anywhere else. Like in the blood, the M spike is 0. The scan, PET scan or CT scan or whatever test you have has no evidence of lesion, and the bone marrow on immunohistochemistry or the general testing is not able to find myeloma cells, then the MRD testing of more deep kind of makes sense to do. Otherwise, I don't think that you always need to do it every time.
Thank you, that's really helpful. And I think for the New Zealand patients too, I suspect most of us are getting PharMac funded, the publicly available treatments, and because they're sort of set down, it's not like there's a lot of choice for most of us. So I don't think we're, like you say, missing out too much. We'll go into the questions in a second. Just before we get onto it though, there's a couple of things I wanted to mention about apps that I've found really useful. And I think a couple of them, at least one of them, you had recommended, Dr. Shah. So I had personally actually gained a lot of weight from dexamethasone. I'm still trying to lose it. One that I've been using, which I think is an Australian one, is called Easy Diet Diary. So I've been seeing an oncology dietitian, and she, like Dr. Shah said, don't count calories. But the Easy Diet Diary is really good because it, not for every food, but it has things like potassium and fiber and stuff like that. So that's quite useful. The other one is Rainbow, and at least the Android app, it's sort of a rainbow with kind of watermelon seeds, and you put in each fruit or vegetable that you eat, and the idea is to try and get a really good variety of fruit and veggies. And the other one is Daily Dozen. So that's not just about fruit and vegetables and grains. It includes other things as well. And I find, that's really useful.
It's got 12 different foods that are considered to be superfoods or very healthy foods, and you can just mark every day, do you get those 12 foods every day in your diet? So it reminds you to eat 12 of these healthy foods every day.
Fantastic. Are there any other, before we get into the questions from others, are there any other apps like that you would recommend that people use?
No, I think the ones you mentioned are great. I think you have to, I think the benefit of using an app is it sometimes makes you more accountable or think about it. So like, I said, okay, try to get 30 grams of fiber in your meals, but you may not know what contains how much fiber. So if you start tracking it for some time, you don't have to do it forever, but you might do it for a few weeks, and then you get a sense of, okay, if I eat this certain way, I'm meeting the fiber requirement. If I don't eat this way, I don't meet it. So then you start learning what foods are rich in fiber or what it is. And so I think sometimes these tracking methods could help you determine what foods to focus on or how to get your calories balanced out. But I don't think that should be the sole way. Is like, somebody who wants to lose weight says, okay, I'll reduce the calories by 500 and then trying to just eat that, and then they restrict and they're like, okay, I need to eat less, and then it's like this willpower and trying to eat less, and then it's not sustainable to keep pushing yourself with like then being hungry all the time. But when you eat more plant foods, they have generally less calories and more fiber, and fiber is satiating. So if you just eat more plant foods, you will slowly move towards a normal BMI just by eating them without calorie counting, because your calories will automatically reduce just because of the satiating effect of the fiber. And that's kind of what we see on the study too. However, for some patients, if they feel it's not working too well or they're finding a little bit harder, then counting, like having an app where you're seeing really where are your calories coming from, where is the food coming from, can help. Like any app that works in the New Zealand would be fine.
Right. Okay, cool. So we'll get on to the question. So the first question is, in New Zealand, we don't have as much variety of fruits and vegetables as are available overseas, and our fruit and veggies can be quite seasonal. So is anything better than nothing?
Yes. And eat whatever is in season. Like it doesn't have to be that you have to only eat a certain fruit or a vegetable, and if it's expensive you still have to buy it. Whatever is in season and you can, like, that would be fine. So eating a variety of whatever you find would be fine. And like beans are things that are like frozen in the pantry. Also buying frozen veggies are equally good, or fruits and veggies are equally good to fresh. Sometimes maybe even better, because as soon as they are plucked, they are frozen. So they maintain the nutrient and vitamin qualities. So that doesn't mean that, if you're eating frozen berries and that it's less healthy than fresh berries, for instance. So, but picking things that are local in terms of fruits and veggies is always better.
That's great. Thank you. And just a reminder for the New Zealanders at the moment, you might see the signs in the supermarket that all frozen berries from overseas have to be cooked before you're using them. I think the New Zealand ones are potentially okay, but those very frozen ones from overseas we've had some issues with. Cool. Next question. What do you think about intermittent fasting?
So good question. So intermittent fasting means that you're eating only between a certain time and not eating all the time. I think in one way it is a method of calorie restriction, because if you're eating the same amount through the day, just not eating a certain time, then you would eat less overall. So for some people who say like, I don't want to change what I eat at all, but I just want to lose weight or something, then an intermittent fasting way could be a way to lose weight. However, if somebody eats a lot during the time they're eating to compensate for the time they didn't eat, then I think that doesn't fully hold true, because you might just eat a heavier meal because you're so hungry when you fasted. There is some suggestion that intermittent fasting may also have positive effects on the immune system and things, but I think all of that also comes from just trying to follow a normal diurnal variation of eating. So eat during the daytime, not at night or late night eating. And then if you do that and you have an early dinner and you have a breakfast, you still have an intermittent fasting happening all the time, because you're not going to eat all night and you finish your dinner early too. So that ends up being at least 12 hours or something. So there's already a part of that coming in for people who eat regularly.
Thank you. I'm not quite sure about how to pronounce it, but is resveratrol is a supplement okay for myeloma patients with compromised kidneys?
I would not recommend it. There is actually one study that was done with resveratrol and myeloma and showed that there were side effects with the resveratrol use. And I'll try to find the study just now and see if I can post it in the chat. But because of that and the significant side effects, the study actually had to be stopped early. And so I don't think that, and the reason resveratrol would be good is because, again, it has like the antioxidants, polyphenols, things like that. So, but you can get that from eating, grapes and fruits and vegetables, that you don't really need to have a supplement of it.
And is that for all myeloma patients, rather than just the ones with compromised kidneys?
that study showed, I think, a renal adverse event. I'm trying to just find this. I think I found the study. So that study did show a side effect for the kidney increased risk, but I would say that we don't have enough data and it's very hard to do these studies. So, if you feel it's helping you for some reason, maybe you could continue, but especially if you have kidney disease, I would totally avoid it.
That's great, thank you. So the next question, the composition and diversity of intestinal microbiota appear to be of high importance. How do various chemotherapy drugs and other medications used to treat myeloma affect a myeloma patient's microbiome, i.e. does treatment promote dysbiosis? How does the diversity of gut flora influence the efficacy of myeloma treatment?
So that's a good question, and the problem with all of these questions is that if we want to know what each drug does, we need to study it with each drug, and there isn't a lot of research specifically before the patient starts the drug, on the drug, post the drug, like that. So it's hard to say what exactly happens. We do know, for instance, with transplant, which is very high dose chemotherapy, that it leads to a reduction in diversity or the microbiome composition just because of the high dose of the chemotherapy, but most patients will recover post the chemotherapy few months later. So I think that I'm sure that most chemotherapy have some effects on the microbiome, and each one in different ways, but I think that we should not be doing the chemotherapy for its risk because of what it's doing to the microbiome, but rather just eating well while we do the chemotherapy and then after as well to restore it. But I can't say that we know that this is specifically to it, because even cancer in itself causes dysbiosis or abnormal microbiome. So there is data that there are these mouse studies that were done where they took stool samples from healthy patients and then patients with myeloma, and put them into mice and colonize their microbiome with these bacteria from the stool sample, and showed that the mice which had the myeloma patient's microbiome actually had faster progression of myeloma in them, and the ones that got the healthy patient microbiome had slower progression of myeloma. And this was not injecting tumor cells from the patient, but both had tumor cells the same amount and just showed slower progression. So the microbiome does affect it, at least in mouse models. In humans, it's a bit harder to fully, tell, and that's some of the studies I showed you. But yeah, that would be my answer.
Thank you. What do you think about a plant-based ketogenic diet?
I think it could be useful or valuable if somebody is able to maintain it and truly do it. A ketogenic diet, the advantage of ketogenic diet is the ketone bodies that may have anti-cancer, anti-inflammatory effects. But with a plant-based diet too, you have the butyrate or short chain fatty acids that are also like the ketone bodies they're both similar molecules. So you do have some of that effect from a plant-based diet anyways. I think if somebody is going to do a keto diet, I think a plant-based way of doing a keto diet is a much healthier way than not doing that. There have been studies with keto diets showing that very high fat diets and very low carb to achieve that ketosis state are associated with reduction in muscle mass or fat-free mass. And so while patients lose weight well, they may actually be losing muscle mass in these studies, and also water mass. So I think keto diets could be a way to lose weight for the short term, but I would not recommend a keto diet for life or long term. Also, people think they're doing a keto diet often, but they're actually doing a low carb diet, because a low carb diet, staying in a state of ketosis, is not physiologic and very hard to do, because you have to eat really, really low carbs, and to eat that little carbs is not what we are built or programmed to do. So it requires a lot of motivation and planning to do that. And so most people eat little more than the keto state, and they are in the low carb state. So the low carb is little more carbs, the keto is much less carbs. So I think a lot of people don't even get to the ketone body effect because they don't even meet that.
you. Are there any particular dietary supplements that have been shown to benefit multiple myeloma patients?
Sorry, I missed the question. What did you say?
Yeah. So are there any particular dietary supplements that have been shown to benefit myeloma patients?
So we know that vitamin D, like I told you, deficiency is associated with reduced survival. So that's one I would repeat. Other supplements, things that we know a little bit of information around would be, the curcumin story, but I think that curcumin also has, and that was only studied in smoldering myeloma. We are studying it now, but I don't think there's enough data to recommend it to patients at this time. And there can be, interactions with chemotherapy or things as well. So it's also expensive to take. So I think I would not like universally tell all patients to take it, but if it helps you, or for some people it helps with arthritis, inflammation, other things, then you could if you wanted to. But I wouldn't take a very high dose, and I would monitor because liver function and other things with it. And then vitamin B12 or iron or things like that, I would take only if somebody is deficient. So it's important to look at if they are anemic, then first checking levels of some of these vitamins. And then calcium supplements you would take if you have gotten a bone strengthener, and then after that the levels are low. But to supplement calcium, more important than that is having normal vitamin D levels, because if you have low vitamin D levels, how much of a calcium you take, you're not going to absorb it. So first thing you want is the levels to be normal of the vitamin D to absorb calcium. And then if you eat just good food or calcium-rich foods, you will get most of your calcium. But if you want to take a supplement, then you can, like 500 once or twice a day. Though too much calcium supplements can also have side effects.
Great, thank you. And just in the chat, someone's just reminded us as well that the monthly vitamin D is often funded for myeloma patients. So as Dr. Shah said, supplements can be quite expensive. So talk to your hematologist because it might be, if you need it, it might already be funded for you. Someone also said it's a shame that your Nutrivention trial isn't being conducted in New Zealand, and I agree. I would love to have.
I would love to as well, hopefully down the road, but it's hard, when we are shipping food and stuff, that we have to find vendors in other places and things. But a lot of this can be done on your own. I think it's finding the right, even meal delivery. If you feel like you can't cook and or have the time for it, finding a good meal delivery company that can send you lunch and dinner instead of having to prepare it. That could also be a way that it takes away the stress from you having to do it, and you get some of the food at home.
It's a really good point. So for those who aren't aware, Whoop, so it's, I think whoop.co.nz, WOOP, they have a plant-based one. My food bag has a plant-based one. I think they might even have two plant-based ones. And there's a couple of other smaller, like I know there's one in Wellington, for example, that is perhaps vegan, and they send out things like in jars and stuff like that. So there are a couple of other vegan kind of meal service things that I know like that, or plant-based ones in New Zealand as well. What else?
I think there was one question on how is composition of the microbiome best measured.
That one's just.
And while a lot of this, when we do these studies, we show you the evidence, it would be nice if we could say, okay, when you come into clinic, we'll check your microbiome and give you recommendations based on that. As of yet, it is not like a approved test by insurance, or because this is mostly in the research area. However, there are some private companies that are doing this for money, where you can, ship them the stool sample and they will send you like a report on what they think your microbiome composition is. The problem is we don't know what to do if they say, like, suppose they say to you, like, okay, there's too much of this strain of bacteria and there's too little of this. We don't yet have enough information to say, okay, how do we modulate a specific strain? But what I can say is that looking at the function of the bacteria, like having more of the healthier butyrate producers, or having the short chain fatty acids like butyrate concentrations maybe a little bit higher, or having more diversity. If there are ways to measure that, then you could if you wanted to. But again, I think that none of these tests are standardized and they're not validated or things like that. So if you do the test, it's not always clear like what to do or make of it, but maybe, you know, if that helps you and it's reassuring for you, you could consider it. But I don't think that it's necessary to do that as of yet.
Great, thank you. So those were the questions in the chat. What other questions did others have? If you've got a question, you can take yourself off mute. I should be able to see. So there's another one from the chat. Is there any information about various fats and oils, for example, vegetable oils and omega-6 fats are anti-inflammatory, but are added ingredients in so many foods, and people commonly use them for cooking as they're cheap versus healthy fats like avocado oil, olive oil, ghee, and balancing omega-6-3 ratio with DHA, EPA?
Yeah, and that's a good question. Often Western diets, because of the fried foods and just overall saturated fat, are very omega-6 rich and omega-3 low. But omega-6 are also necessary and healthy, so you can't say that you have to completely avoid them. I think it is what you're thinking about. It's like each food you want to make sure that it's like less fried or less processed or things. So in a practical way, I wouldn't worry too much, but trying to pick the healthier oils. So things like olive oil, one of the most healthy oils. So if you're picking something to like cook with or eat with, then picking something like that. With omega-3, every person is different, but there's no good way to measure and say, are you somebody who needs more omega-3 or not? What foods that are rich in omega-3 are flaxseed, chia seed, walnuts, hemp seeds. So trying to incorporate these things in your cooking or your food, that could be a way to get a little bit of omega-3. But those omega-3 are usually more the plant-based omega-3s like ALA. Another way that if you really feel like omega-3 is important for you is getting it through a supplement. So algae oil supplements, you get it directly from the source because fish eat algae and then they get omega-3. But if you just directly eat the algae as well, you can get directly the omega-3. So we are using an algae oil supplement on our trial to understand its effects on the microbiome, and hopefully in a few years we'll be able to share that information to see what it is. There are some cell line studies with omega-3 showing that maybe it reduces inflammation or inhibits myeloma cell line growth, but all of that is like very like what happens in the cell line may not happen in humans. So I don't think we have enough information. I would prioritize unsaturated fats over saturated fats whenever possible.
Thank you. Again, I'm not sure I'm going to pronounce this right. Is it psyllium husk a good source of fiber?
So all of these fiber supplements like psyllium and senna and all of them, they are all good sources of fiber. But the problem when you eat fiber supplements, they're often one kind of fiber. And we know that there are actually many types. There's soluble fiber, there's insoluble fiber. There are a lot of different types of fiber. And every food you eat has different fiber in it. So that's why and every microbe needs different fiber. So getting your fiber from a variety of foods leads to a variety of bacteria because each of them eat the different fibers. If you eat only one kind of fiber, while it's still better than not eating fiber. So if you're somebody who's like, I'll never change my diet, then maybe just adding a fiber supplement could be worth it. But if you can get your fiber from directly eating a variety of plant foods, that's a better way to get fiber than just one supplement which has one kind of fiber.
A question around probiotics. So I think, you know, when you have the probiotic kind of pills that you might get from a chemist, I think there has to be careful around, you know, timing with antibiotics. If someone was to eat foods with probiotics in them around the time they might take their lenalidomide, for example, and other myeloma medications, do we need to be careful about that, or is it kind of different?
So you remember that one study I showed you in melanoma or skin cancer, that people who had sufficient dietary fiber intake had better progression-free survival on checkpoint inhibitors, so immune therapy. Now, this is skin cancer, it's different than myeloma, but you're seeing that adequate dietary fiber leads to better progression-free survival. However, they also showed that people who eat adequate dietary fiber but were taking probiotics had worse survival than those who didn't. And that same study, I didn't maybe show you the curve, but that curve of adequate dietary fiber with probiotics was similar to inadequate dietary fiber. And the thought with that is that sometimes probiotics are very few strains of bacteria. So instead of enhancing that diversity, maybe they are reducing diversity, or we don't know if the strains that they have are the healthy strains, because a lot of the strains that we know are associated, like butyrate producing strains, are usually the anaerobic strains, meaning bacteria that need less oxygen, or so it's harder to grow those and harder to make probiotics with those. So the probiotics often don't have the strains that we consider often to be the healthy strains. So I think it is more important than eating like a probiotic supplement. Again, coming back to it, is trying to get fermented foods like maybe even kimchi, sauerkraut, things like that, and then also getting enough of the variety of fibers to help. I think probiotics could be like in short courses, if around like an antibiotic use or something, somebody felt like it's helpful, but you don't want to take prolonged probiotic courses, especially when you're immune suppressed, because there is a risk that those could lead to bacterial infections too.
It's really interesting, thank you. Are there other things like that myeloma patients that you found sometimes do, thinking that they're doing the right thing, and say for example it could end up that they're actually a blood thinner or something like that? Are there things like that as well that we might not think of that you could tell us about?
You're asking if there are other things that patients should do in general, like,
or do or not do, or say for example, do you see patients doing things thinking that they're doing something that's healthy, but like how you talked about probiotics, I think people think, oh, if I do that, that's a good thing, but there's those kind of unintended consequences.
So I do sometimes see like patients, when we go over their med list and we'll ask them what they take, and you'll see like they're on 10 or 20 different herbal supplements, and they're like, okay, this supplement is supposed to be good for that, and each of them are plant-based supplements, because they're like each herb purified form of a certain herb, and that's what the supplement is. But what they don't realize often is that when you take so many different supplements plus you're on chemo, there are a lot of drug interactions that could develop, and that could actually increase risk of liver toxicity, liver failure, other risks as well. So I'd be very cautious to take so many high dose supplements simultaneously. And there are side effects to them too. Remember, some of the chemotherapy that we have actually been derived from plants. So chemotherapy, if you think about it that way, also has a natural origin from a herb or a plant. So it's not like it's always synthetic or chemical and the plant thing. So it's a lot about what the dose matters. And the problem with supplements is that there's not a lot of data on it, because there's no incentive to do these trials, and the supplement industry makes these, but they are not mandated to do a study before they sell it or prove it. So we have thousands of these supplements, but we don't really have evidence and to do trials with each supplement. As you can see, like each of our studies takes us like 5-6 years to do, a lot of funding requirements, and it's complex to do that. It's really not possible or feasible to do it with all supplements. So that's one thing I see sometimes.
Thank you. Another really useful website that I just thought about to mention, which is actually from Memorial Sloan Kettering, is the About Herbs website and app, because I think most of us will probably know, say for example, if we are on bortezomib, it's recommended that we don't have green tea. There's certain things if we're on blood thinners that it's recommended that we don't have. And the About Herbs website and app is fantastic. You can put in, say for example, you could put in bortezomib and it will talk about the risks around green tea, or you could put in green tea and then it would have bortezomib. When you're on the actual website, I don't use the app, but on the website you sort of want to click in because there's a couple of different places. I think you can even just put in quite generic stuff like blood thinners, and it might tell you, I don't know, don't have ginger, or I'm not sure, but you know, things like that. And it's another really useful one as well.
It gives you, like, it has from A to Z, like all the supplements. There's an app version called About Herbs app, but there's also, like, you can click, suppose you say biotin, you click and they'll give you all the information on biotin, what are the drug interactions, doses, side effects, things like that, that's known to date for it. So if you really do decide you want to take a supplement, then that's something you can look at to see if it's important for you.
That's great. And always remember as well, to check in with your hematologist as well, because like Dr. Shah said, it could be something that interacts with something that you're on. So you always want to check in with them or your myeloma nurse if you've got a myeloma nurse as well. Someone's asked, could you speak again about curcumin and chemo, for example, lenalidomide? I'm not quite sure. That's quite a general thing. I'm not sure if the person wants to put a little bit more, or if that's enough for you, Dr. Shah.
I'm not sure what the question is, but there is no study looking at that I'm aware of that looks at curcumin and lenalidomide together. The studies that were done with curcumin were in the precursor states, like smoldering myeloma, but there hasn't been a study when they are on lenalidomide maintenance. Yes, that would be interesting to see the effects of that as a combination. We don't have a study looking at it as a combination as of this time. But I think when we get the data from on the effects of the supplement on the microbiome, we can then try to think about what lenalidomide does, what curcumin does, and maybe understand a little bit more of whether there is a value to studying it together.
Okay. And I also understand is curcumin a blood thinner as well. So myeloma patients, if they were on something like rivaroxaban, potentially wouldn't be able to take it anyway.
I think the risk of bleeding is low. It is a risk. So, but even if you're on a blood thinner, it may not be that higher risk. And I would just take a lower dose if somebody's on a blood thinner, or not take it at all. But I don't think, again, that's the problem with supplements, that it's hard to say, like, if you take this dose level, this is the risk of blood thinning. If you take a higher dose, this is the risk. So we don't really have true numbers.
Thank you. All right, any other question? You can also use the raise hand function down the bottom if you click on reactions if you want to, or if you take yourself off mute. I should be able to see that you've done that, or put them in the chat. Yes. Nori, I'm not quite sure your first name, sorry, I've got a question.
No, I just wanted to say that Dr. Shah answered the question I had about curcumin really well, really satisfactorily. Thank you very much indeed.
Okay.
I agree that it's very hard to know what amounts of active ingredients are in supplements very often. Thank you.
Yeah.
Anyone else? Looks like it might be the end of the questions. Dr. Shah's also put the link to the about herbs in the meeting chat. And if anyone missed any of the things that has been spoken about, you can always send through an email and we can help you with that. Right, well, I think that's probably, we've come to the end of things. Let me just check if I had any other, no, that was all. Great. Well, thank you so much, Dr. Shah. This has just been absolutely fantastic. As I said, I would really encourage the rest of you, if you're on Twitter or Instagram, to follow Dr. Shah. And I'm not sure if you post things to LinkedIn as well, but I found it really, really helpful. And we've got a lot of comments in the chat as well about how this has been a really great session. Is there
I'm
anything
so-
you'd like to add, Dr. Shah, before we finish?
No, I was just saying, I'm so glad you all stayed and listened to this and were open-minded to hear. I know sometimes it can be a lot, but just stick with it and do the best you can. But I don't want this to be where you come away from this feeling like, oh, I did things wrong or I'm guilty about it, but thinking about like how you can make small changes to just improve. Like sometimes when we do get these grave or difficult diagnoses, that's the time when we start thinking about our health overall. I had Hodgkin's lymphoma in 2016, and that kind of brought me to start thinking about these things and why we should study it for patients, and helped me start researching this. So I think sometimes when we do get these difficult situations, that's when we realize or think about where to make our best improvement.
Great. And so you definitely know what we're going through then as patients.
I do. Yeah.
Great. All right. Well, thank you very much. Have a good evening and have a good rest of the day to everyone else who's in New Zealand. Thank you very much. See you.
Very nice. Bye.
Bye-bye.